Good morning, everyone. We'll go ahead and get started. You should be able to see the screen being shared, hear us via audio. The video of us is a green rectangle, and we know that and apologize for it. And that will be the view today. As a preview for Grand Rounds for the month of December, of course, today we have the discussion or the presentation from Dr. Moore, Dr. DeCamp on the patient experience in the digital communication age. Next week, we have Dr. Caroline Robb, a cardiothoracic radiologist, coming to talk to us about chest x-rays, tips and tricks for primary care. Followed the third week of the month, the quarterly business meeting. So again, for today, we're very excited to have Dr. DeCamp and Dr. Moore join us for background. Dr. Moore attended college at Wheaton College, medical school at Oregon Health and Science University, residency at Providence Health System in Oregon, in fellowship in integrative medicine at the University of Arizona. And she is board certified in obesity medicine and in the process or has completed certification for the patient experience exam. Dr. DeCamp did undergraduate at Purdue, MD and PhD at Duke, residency at University of Michigan, and a fellowship in bioethics, health policy, and GIM at Johns Hopkins University. And he is also in the Center for Bioethics and Humanities. And again, we're really excited for them to talk to us about Beauty and the Beast, patient experience in the patient consumerism / digital communication era. Questions for people in the audience as we go. Please ask questions along the way. Raise your hand and I'll circulate with the microphone. For those attending virtually on Zoom, please go ahead, type those questions into the chat, and I'll be fielding those along the way as we go. And with that, I'll step aside for them.
Thank you, Steve, and thank you very much for this opportunity to speak about this topic. I'm really delighted to be here, and I'm particularly delighted to share it with Matt DeCamp. We have the privilege over at the Cherry Creek Clinic to see Matt as a clinician and admire his patient experience skills. So very authentic to share this with him. So we are going to talk about patient experience today, and particularly how it's assessed. And we really want to stimulate dialogue and conversation about, is it being assessed in the proper way? We neither one have any disclosures, although some might say I'm old. Sorry. Okay, for our learning objectives today, we are wanting to really have people understand where the current patient experience assessment stands, and to look at some existing research, most of it done within our division and organization here by Matt and a bit by me, to understand where people are right now with digital communication and how it impacts patient experience. And finally, we'd like to allow quite a bit of time at the end for discussion about how could we do this better. I don't think I need to dwell for this audience on what the beast is. I like this quote very much from the chair of Department of Medicine at UCSF. Many years ago, we turned on patient messaging 24/7, 365, and of course, all the patients love it. And we had no model on how to handle it. With that said, I want to shout out to our organization, which is really making efforts on this between Tactic and Thrive, Taming the Inbox, Abridged Notes. And yet, I think for most of us, we still can feel fairly overwhelmed in our clinical day with this topic. I also would like to call out Slow Ideas. This is a really well-known paper that was written in 2013, quite some time ago. But I think it's really true, the concepts and the conclusions Atul Gawande makes. The point of his is, why do some things move through healthcare really quickly and other things take decades, even though there's an evidence-based background to make them happen? And I might highlight, for example, the Abridged Notes. They're taking the country by storm. They're good for patients and they're good for doctors. He highlights in this paper HPV and cervical cancer guidelines. It took years, decades to, even though that was a solidly understood connection before Pap smear guidelines were changed. It's probably good for women not to have a pap smear every year. It maybe wasn't so good for gynecologists. And so the challenge as we sit through this discussion is we'd like you to think about, with patient messaging particularly, and other forms of digital communication we'll discuss, think even message appointments. How could we make these good for the clinician? They're good for patients. Patients like them. But how can we make this good for the clinician? And can patient experience assessment be a tool for us to find a way to be innovative in making digital communication good for us? So first of all, I'd like to define patient experience. 2 or 3 of us in the room were participated in this definition. There's a number of definitions out there. This is the one we designed last in October, actually. And the key to this I'd like to highlight is it's more than face-to-face care. All interactions, which will highlight sort of where those are part of the patient experience in their journey of care, particularly in a continuity practice like ambulatory internal medicine. So now I'm going to try to convince you there are 5 reasons we should care about this. A growing body of literature shows that a positive patient experience correlates with improved health outcomes, quality, and safety. And I've given a couple reference review articles on this. I don't think that's a surprise. We know adherence improves when patients feel trust that they're cared for and trust the clinician they're seeing. Also, there's both indirect and direct revenue linked to patient experience. I worked hard for this talk to try to get some real numbers on what health systems are receiving in direct dollars based on the surveys and patient experience scores, particularly in our value-based contracts. I wasn't able to get that data, but something less than 2%, relatively small amount, is direct revenue related to patient experience. Indirect, though, there's quite a bit of data, and I think UC Health is a good example of market share growth due to the positive reputation of our organizations together and how that has brought more revenue to the system. I'd like to talk a bit more on the darker side. The patient consumerism movement is rapidly growing, and this is an example of a patient of mine I've taken care of for many years, a 73-year-old, very articulate person. She had messaged me 29 times in 26 weeks about different things, requesting referrals and x-rays she thought she needed and various things. And I had pushed back that she needed an assessment. But like many patients, she'd made her own assessment and plan and was messaging me with her order and asking me to fill it. I finally had her come in, and her comment to me, "It's my patient right to be able to message you." And I'm not sure we've decided as a profession if it is the patient right to message us. And particularly to us directly. But this was her attitude, and I think we see this more and more where patients do feel they're in charge, which is great, and getting their own assessment and plan outside of the standard medical visit. I also wanted to share this, which is really was quite impressive to me. This is a younger woman who sent me, after she had some spinal x-rays, her conversation with Claude about her interpretation of her x-rays. Claude did a great job. I was really impressed. I'm like, why don't I have Claude to respond with my results? Because I was really impressed with this. And the only negative was her conclusion was that she needed a spinal MRI, which is not what Claude said, but that's what she wanted. And again, just another example of how our patients are getting information from many sources and we're only one source. On sort of the dark side, I don't know if some of you also read the article by Dr. Bernard, who's one of the opinion writers in the New York Times Sunday, about the Children's Health Defense meeting in Austin last month, where over 1,000 people were in the room to hear about the parent of one of the measles deaths in Texas And his expert, another physician, saying that this child, 8 years old, did not die of measles. She died of hospital-acquired pneumonia, and of course, he would never take his children to a hospital again. So things are really, the conclusion she made, I encourage you to read, is around how we really do need to listen as the scientific method is becoming more and more controversial for a growing percentage of the population. And can patient experience be one of our bridging techniques? Can we learn from a better patient experience assessment on how to bridge and find common ground in sort of this growing part of the population to hopefully help with their health decisions? And finally, I think we should care about patient experience because of meaning in our work. One of the joys of our work is we still do enjoy autonomy in how we communicate with patients, both in the written and face-to-face interactions. Competency is a way we can expand that in our written communications to patients. And what I feel is probably most important for those of us, which are most of us, intrinsically motivated to, because we're internists, the need to be connected and relate to our patients and have that meaning of our work. So with that said, what are the current state of patient experience assessments? Currently, most patient experience assessments are still done on face-to-face meetings. The inpatient HCAPS you're probably familiar with. It really became required for hospitals in 2007. So we've got about 20 years. It was developed in 2002. And the outpatient one was much earlier. That started in 1995. And so we have about 30 years experience. These really haven't changed much. They have different vendors. Our system has worked with both Press Ganey and NRC Health, and they deliver this and report them back. And what do these include? The key contents of the HCAPS is, again, system issues around was your room cleaned and also did you feel listened to and cared for interpersonally in the hospital? And similarly with the outpatient surveys about access, did you get an appointment, and sort of the respect shown to you in your interaction? Were you listened to? And they do now ask also if any of the visits were on video. But overall, these have been pretty much the same for the last 2 to 3 decades. So we created this funnel for this presentation, and this is probably about a year or two old data, and I expect the top 2 levels will flip eventually. About 1 billion calls are made to healthcare clinics in the US. No assessment of how that works. More and more of these may be answered by a chatbot. 230 million people portal or message their physicians, and a third of those 6 or more times a year. Again, the visits made annually, which are assessed in surveys or opportunity to, as we're familiar with, but a tiny percentage of the visits actually result in a responded survey. And with hospitalization, we do a little bit better, with about a third of inpatients responding to their surveys. So as you can see, we might have room for improvement on how we're assessing patient experience. This is a quote from the Barrel Institute white paper, again, 5 years old, but still pertinent, I think. Barrel Institute is thought of to be as the think tank for most patient experience nationally and even internationally. They're the ones who do offer the certificate of a patient experience professional. So they would suggest that we haven't done a great job of measuring ourselves, and that these programs have kind of created a teach to the test model where we emphasize the particular questions of did you feel listened to and would you recommend? And when we're doing such a small percentage of touch points, that might not be as educational or helpful as possible. Here is an overview nationally of what's happened in the ways patients use portals. And as you can see, there's been a huge growth that happened really, starting in 2013, 14. But the number one way patients still use the portal is by viewing results. As we are all familiar for, making appointments has been pretty stable over the last several years. And this would suggest that messaging providers, while it had a big growth during the early pandemic, has stabilized. That's not true in our system, as I will show you. And also, increasingly, patients use the portal to view their notes. And I certainly am seeing more feedback from patients after starting a bridge, and I appreciate that collaboration with them. So for us here in our system, we have 2.7 million portal users that are affiliated with the UC Health system. And as you can see, we've had about a 22% increase since 22 in people messaging per month. And this is consistently going up. We get this information from Matt Angelosa, who has been very helpful for us in our research about digital communications with patients, and steadily increasing. The new area of the chatbot also is rapidly increasing, and I know when Matt and I first saw this data, we were a little bit stunned about the growth potential when you see that only 5% of users are messaging per month. And with the rate of growth, you can easily see what that would mean with only a few percentage points increase over the next few years in the volume of My Health Connection messages we'll continue to receive. So, our conclusion so far is that there are no formal patient experience assessments for most frequent touch points with their healthcare team. And really the question for the discussion is that the most helpful, particularly when how it can impact outcomes and patient safety and quality? I will argue that the beauty, and I think we will, that if we find out ways, and there are efforts to make more creative ways of patients entering in assessments of the patient experience, but they still require people being in a face-to-face setting. But if there's a way we could find opportunity to get assessments done of patient experience with digital communication, I do think it may be a tool for us in bridging some of the challenges ahead and hopefully finding a way to manage this volume. So with that, I am going to turn it over to my colleague.
Well, thank you for that, Annie. Thanks for the opportunity to be here and present some of our work on digital access and patient experience. I do want to recognize at the outset, Annie, your work with the collaborative and more so future-oriented and innovative in its thinking. I think the subtext of what you've been describing so far is that patient experience measures need to change, and they're going to change, and we have a role in helping change those measures for the better. So I appreciate all of your work. I also want to acknowledge as I present some of our research findings here that I'm presenting on behalf of the team at the Center for Bioethics and Humanities. Annie's on the team, Eric Campbell, we have a postdoc, Micah Hamer, who's now tenure track at the University of Maryland. We have many research assistants. Marley Eckerson is a School of Medicine student here now. And Natalia Della Valle is a medical student now in New York. Jess Ellis is still in our center. So we have a big team, and I'm representing that team when I talk about our particular research study. So I'm going to move to talk about AI and AI-based communications, and I'm going to start by pointing out this important feature of the recent AMA toolkit on governance structures for AI and the implementation of AI in healthcare. And just to highlight that patient experience is going to be one key component of these toolkits. Various ways to measure patient experience or have it influence the way AI gets implemented in healthcare, but just to note that it is a key point. And so to reiterate, this is going to be really important looking toward the future. So what's our research study about? Well, our research study is about Livy, that general patient-facing chatbot. When I started talking about Livy a year or two ago, I think most people actually hadn't heard of Livy on the clinician side, but now I think most people have seen Livy. the UC Health virtual assistant. Again, major thanks to Matt Andazola at UC Health, who's been a partner in helping us do this research. In the center, you see a conversation I had with Livy on mobile phone, where Livy directed me to advanced care planning. Livy's not an LLM. This isn't like ChatGPT. This is more rule-based at the moment, but the LLM version is coming. You can imagine there's a lot of potential for patient-facing chatbots like Livy. They can offload some of those administrative tasks like scheduling. It's already been foreshadowed by Annie's comments. Livy can actually deliver personalized care recommendations like colonoscopy or mammogram reminders. So Livy, as a general chatbot, is linked to your EHR. Some would say Livy knows you. So at the end of this advanced care planning conversation, Livy could say, hey, Matt, noticed you're overdue for that colonoscopy. Can I help get that scheduled for you? So this personal notion of personalized care via the chatbot. And of course, in a state like Colorado, where we care a lot about rural communities, Livy can break down geographic barriers to access to care. So a lot of potential in that regard as well. But we're talking about patient experience today, so we're asking a little bit about what do patients think about interacting with Livy, this chatbot. And just one other thing about Livy. Livy's meant to be a general patient-facing chatbot. There are plenty of chatbots out there. COVID-19 symptom checkers during the COVID pandemic. Chatbots that can deliver genetic test results. Those are narrow. Livy is meant to be a general chatbot to have much more all-purpose general features compared to some of those others that you might have heard about. So to help understand what patients think of the experience, we did a mixed method study. It was funded by the Greenwall Foundation over a period of about 2 years. We did semi-structured interviews with more than 40 patients, and we did an electronic survey of more than 600 patient users. In both cases, we actually developed a sampling strategy that was purposeful. We tried to oversample people of color and others to make sure that we had a balanced sample that we could use for some of our analyses. I'm happy to talk more about the research methods if you want. Today, I really just want to focus on those main lessons we learned from this Livy study. Lesson number one is sort of a basic question of ethics, and I've shared this a number of places, and the lesson is that transparency is not as easy as it seems. We asked in those surveys a very simple question of patient users when you were interacting with Livy, what do you think Livy was? And you can see here, 1 in 3 weren't sure what Livy was, and some thought Livy was an actual person typing back to them in real time. What's more, correctly identifying Livy correlated with education and race or ethnicity, not age, gender, or income. So integrating issues of justice and concerns about social justice alongside those of transparency. So transparency, a key topic when it comes to digital communication, but challenges in the real world. Lesson 2A, I describe as that the Livy experience affects how patients perceive the health system. This is a complicated slide, but what it's asking in the middle and in the top is asking patients to rate how well they thought the chatbot understood them and how well they understood the chatbot. And what we found is that if patients cannot understand Livy, or Livy cannot understand them if they perceive that, the patients actually perceive that Livy's intent could be to hinder access to the health system. So if you're having a negative interaction, a negative digital experience with this chatbot, you then extrapolate to say, the health system is using this to get in the way. This is meant as a barrier to me. So Livy affects the way patients experience the health system. Again, think about those experience measures. You can see how this is going to play out. Lesson 2B, you all won't be surprised that there are still a number of digital access barriers that remain. Annie showed the data that really only 2% of patients in the system are using Livy, but they are using it in a tremendously high volume. You can imagine, therefore, that many patients are not using or perhaps left out of technologies like Livy because of digital literacy and other concerns. And these are quotes from our interviewees. You can see on the far left, my grandparents don't have smartphones. They wouldn't be able to use chatbots. And those quotes are reflected across the board there. So access concerns clearly abound. And then really interesting, I didn't show you this quote, But some of the users told us they felt like they had to talk to Livy. So I don't know if any of you don't need to share if you've interacted with Livy or pulled it up on your phone. But when you pull up UC Health, Livy does kind of pop up at you and says hello. Some of our users felt like that when that happened, they have to go through the chatbot. Now I have to talk to this thing. So they felt forced into this mode of communication, which some of them weren't necessarily comfortable with, either because of typing or technology or other kinds of barriers. You can imagine what they all might be, even visual barriers and so on. So interesting questions about access and how people perceive a technology in the real world. Lesson 3 builds on those two, and you could probably see this coming as well. The Livy experience intersects trust in the health system. So in our study, we found that older users were actually less concerned about privacy with the information they shared with Livy. This was surprising to us. I think we came in with probably an ageist assumption that older users are going to be more concerned about what they say to a chatbot like Livy or what they type to a chatbot like Livy. But they were actually less concerned. And the reason for that was because they attributed trust in the health system to Livy the chatbot. We called this in our study a halo effect around trust, that because you trusted the health system and you trust the way the health system processes information, you therefore trust the information that you're sharing with Livy. We heard that also in some of our interviews really helped us understand why patients answered this question this way, to understand that why question compared to the survey. By contrast, younger users were more concerned about privacy, should be more concerned because they associated Livy as more of a marketing tool. So interestingly, the younger users in our sample, when they saw Livy pop up in that same way, they assumed that Livy was a marketing chatbot like you might see on an online website for an insurance quote or something else. And so they discounted, oh, this isn't healthcare at all. This is one of those marketing chatbots. Very different experiences intersecting with trust in the health system. And likely to affect some of those patient experience measures, going back to the point that was made, we have this huge trove of interactions that aren't necessarily being captured, but probably are maybe indirectly being captured in some of those measures. Not very well, though. This is a figure from Annie's paper, work on this topic, and this figure was built on the interviews, and it just shows you the complex ways that in the center, patient-level factors interact with chatbot-level features and factors to affect that experience, the way people experience a chatbot. And then really importantly, I think the green circle represents all those system-level factors that similarly influence that interaction. You know, we think about these current patient experience measures, and a lot of them do focus on that individual level. Individual patient, did your provider listen to you, and so on. But think of all the system level factors that are at play that might influence the way someone answers that question. And then, of course, in the upper right, what I hinted at before, the patients who are excluded from access altogether. The more we go this route of digital communication, digital access, when people are left out from that, their voice doesn't get heard. Almost done with the lessons here. Lesson 4, prior experiences in healthcare drove some patients to Livy. This is a really interesting study. It was led by Natalia Della Valle, who's that medical student in New York now. And this figure was created to show on the left the tasks that people went to Livy for, and on the right, the motivations for why they went there. I'll just call your attention to the lower left, which are what we described as sensitive tasks. People wanted to go to Livy, the chatbot, for sensitive issues like mental health, gender, sexual issues, and so on. And the reason for that, linked on the right, you can see, is because many times they wanted to avoid judgment. They wanted to maintain anonymity in the conversations they had about those topics, maintain privacy, and so on. Many times when patients told us about this, they were referencing prior interactions with the healthcare system where they felt judged or felt like they'd experienced bias or discriminatory care. And so they preferred to go to a chatbot for these reasons compared to a human. Many patients also told us, by the way, that when they interacted with the chatbot, They did not want what they shared with the chatbot to be shared with their care team. Did you have a quick question?
Like those other chatbots where you can scream, you know, agent, 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 when you actually want to talk to a human. Sorry.
Yeah, no, Liv, the question's about Livy and whether you can scream agent, representative, and get to a real person. The answer to that is no. Yeah, it doesn't work that way. Lots of fun stuff with Livy, though. Spanish language, not just typing anymore, vocal interaction back and forth. There's a lot of fun stuff coming, so be on the lookout. This is my last slide. It's not about Livy, really, but it's to bring back the idea that when we think about digital communication, digital interactions, it's not just about the message. It ends up reflecting on the messenger. That is, it ends up reflecting on us as clinicians or us as the health system. Let me illustrate this by moving to some of those AI-generated LLM smart replies that you've probably all seen in your in-basket. Message comes in, initial smart reply is generated. You may have heard that those replies are more empathetic, so to speak, than physician replies. And just to caution you, don't believe that study. There are lots of problems with how that study was done. I'm happy to talk about them in Q&A, but that wasn't really a fair study, one would say, about the way people communicate. But in any case, it's not just about the message, it reflects the messenger. So let me give you this particular study. This was not in a healthcare setting, but when people were interacting with smart replies, perceived use caused the recipient, who could be a patient, to review the sender, who could have been a physician, more negatively. Perceived use causes the patient, could cause a patient to review the sender, the physician, more negatively as a person, not the message. This is about the person. But actual use caused the recipient, who could be a patient, to review the sender, who could be a physician, more positively. So in this case, we're in an ethics quagmire, I would say. It would suggest that this AI smart reply supports relationships, but only if patients don't know it's being used. And that, you can see, is an obvious ethics tension with the first concept I presented, which was around transparency. So don't forget, it's not just about the message. The way we use digital communications end up reflecting on us as people as well. I'm going to turn it back to Annie for a different study.
We were fortunate to launch this study that was with Accords and our team funded by the Endowment for Patient Experience on pretty much 3 weeks before the COVID pandemic. And this was a study, there's not a lot done in this space. Ohio State has done about how does messaging, this is the pre-AI generated messaging, build trust and positive patient experience through messaging. Again, similar to Matt, we did 51 mixed method interviews for this. And I'll just highlight the conclusions of our study. As similar, it was positive, particularly, I think, because of the timing we did that. It's almost hard now to remember 5 years, 6 years later, what the emotional tone was in early 2020. But we conducted these through all of 2020. And particularly if patients felt they knew the person they were communicating with, they really found that as a positive bridge for their care. And also the promptness of the reply. Some of our biggest challenges in responding to messages, digital communication of that form, is the promptness of the reply and having the person intended to, as the receiver, to be the respondent. And those were both important for positive experience and trust formation. Also, the system issues, again, were highlighted as far as security and reliability. And also the fact, trusting that the physician would not use this digital platform to communicate really bad news, that they would pick up the phone. Again, this is just our summary of this work, and it is published in GIM in 22, if any of you are interested. Okay, I'm going to turn it back over to Matt, who's going to lead our discussion, and we'll be happy to take any questions first about that. Oh, sorry. I did forget this slide. This is another Barrel Institute slide about how they feel that patient experience assessment should be like Uber. And Amazon was another one. Okay, there we go.
Yeah, I think if there are questions about what's been presented thus far, we're actually purposely left plenty of time for discussion and conversation. So if there are questions about presentations thus far, we're happy to take those now too.
We do have some questions in the chat. One is what came around the time, Dr. Moore, the first time you spoke and you were presenting the data about the number of messages UC Health gets per month from about 5% of users. And the question was to the effect of, well, how many of those are for primary care? Which sort of leads me to my follow-up question, which is sort of proportionally, how much of the footprint does primary care receive of those messages for the clinical care that's delivered?
It's an excellent question. We know for sure that the greatest burden of messaging is with primary care. I don't have the exact percentage of that. It's an interesting question.
And then a question that came up related to some of the material Dr. DeCamp was presenting, which it seems, this was with the discussion about Livy, it seems the desire to offload tasks from providers in the health system onto patients continues to grow. What impact do you think this continual offloading of tasks onto the patient has on the patient, what patients expect and on their experience?
Oh yeah, it's a great question, and I actually appreciate the question in part because we don't we often when I say something like offload tasks, we actually are often thinking about the more clinician side, that we've offloaded scheduling away from the provider, if you use that term, onto the technology. But what I like about this question is it's actually suggesting that we're indirectly offloading the task really more onto the patient. And that is a different dynamic. It probably, I don't know if you may have thoughts on this, I think it probably reinforces that consumerism type movement, whether you like that movement or not, rightly or wrongly. It probably reinforces that idea that if the responsibility is more on the patient for completing some of these tasks. I don't know, you may have comments on it, but yeah. Rob has a question.
What are the liability impacts of these chat box? If a patient's trying to message me, they get some reply from Livy instead of me, and it's an adverse result. Am I somehow liable for this because they were trying to get a hold of me, or is the system somehow reliable?
Yeah, not you as an individual. Although that does go back to why we think it's so important to understand the patient experience of these tools, because they do come with these expectations, right? That like some of them expected that whatever they talked with Livy about, copy and paste into the EHR for you to read, right? And that's not true. They are told when it comes to clinical questions, they get that standard disclaimer that you would fully expect that, I can't offer clinical advice. You can talk to your, provider about that issue. So it wouldn't be you. The health system would take that on. And the other just concrete point, if you're interested in some of the nuts and bolts of Livy, is that technically Livy is still covered by HIPAA because it's under the health system. So that information is protected in that regard, to the extent that you think HIPAA protects privacy.
I'll just add one more to this. It has been, and there are samples surveyed in Livy as well as in messaging, despite all of the warnings about not putting urgent concerns. Suicidal ideation as clearly coming through in both Livy and messaging. And it's, again, part of our challenge about our promptness of reply. And I think we've all probably experienced some of those examples.
Yeah, when Livy and other chatbots move to the more LLM type performance, that's where it gets really challenging. If you haven't read the news coverage of the, I believe, 17-year-old boy who committed suicide after conversing with ChatGPT, if you haven't read what the chatbot was saying back, you should read it, and it's really disturbing. So when they move to that functionality compared to the tighter functionality of Livy at the moment, that's where things can really get problematic.
I'm assuming Livy was not a internally developed, homegrown chatbot, that it was probably a third-party application that the university bought. Is that correct?
Livy, the technology backbone behind Livy is Avamo, is the company. Although on the UC Health side, like we do with the smart replies and other types of technologies that UC Health is using, there's significant customization. So a lot of adaptation.
But I guess I'm getting at that, like, I don't think that was the patient the customer when UC Health decided to spend however much money to partner. Like, we're asking, I don't think so.
Sorry, can you say, was the patient?
What was the patient who Avano was trying to sell us on, or UC Health on? I doubt it. I imagine their pitch was that we get to offload, quote unquote, and now you get to save cost on staff. I mean, it was a kind of and so I'm just wondering, like, I get the point about we need to measure patient experience, but was that what Livy was about?
I don't know the factual, part of it's a factual question, but
point, right?
Which you're implying the answer to.
Well, it's just, I don't think these things are bought and spent money on necessarily. I don't know. To impact patient experience. How many people did they not have to hire to be in the call center? How many, And so I just wonder, if, these things that are designed not necessarily for patient experience, but for cost savings, like maybe the bigger picture should be like, what is the impact of Livy on our healthcare workforce?
Yeah, well, that could be one. Or I guess the other response I have to your question, you may have responses to that. Number one, I think one point we're trying to convey is that whether or not Livy was designed with the patient experience in mind, patients come clearly to technologies with expectations and assumptions and the implications that follow on patient experience. And then perhaps the second question that is the upstream question that you're asking is, and maybe it relates to the conversation we could still have, is what if you design Livy with the patient experience in mind? How would it look different? Or to your point about, and points you made about wellness in the healthcare workforce, what if these tools are designed in that way rather than the financial issues you were hinting at?
Do we have time for one more question, or do you want to move on to your discussion here?
I don't know. We still have 15 minutes for that. Yeah.
Well, maybe my comment hopefully aligns a little bit with this. Like, it seems like, I guess where I'm struggling with is like, how much are we quote unquote consumer centric? Like, right? Should healthcare be kind of like Amazon, like your 73-year-old patient, where you can just be like, oh, I looked this up and I want to click, 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 click. And I just want you to order that because right now you're quote unquote in the way of my Amazon instant delivery order. I wanted on my doorstep yesterday. Versus like what is actually good health care. And that's kind of maybe answering some of these questions, but this is kind of where I'm struggling of like, I still want to be a physician and I still want to do what's right for my patients in this setting where they have access to all of this information and a little bit too much access to me probably.
Yeah.
And I actually was going to ask something similar, phrase a little bit different, which to the point of Dr. Moore, your patient's quote of, I have the right to send messages. And for me personally, I would agree with that. And I think part of my role as a primary care physician is when it's needed to redirect some of those messages to be a visit, I have to say that.
And you take me back. I totally agree with the questions, the comments. I want to be a physician too. And that's why I find myself being annoyed, which I used to be wearing an Oura ring. And it was amazing. I never felt stress when I was seeing a patient face to face. But when I was in the in-basket, woo, and it's because of the internal conflict I feel about. And this is where I personally have never been trained on how to use bridging skills in digital communication. And I feel like we're going to need to emphasize that if we're the ones responding, particularly to find common ground with patients, because again, patients, a certain growing percentage will just go elsewhere. As in this patient, my 73-year-old, she's not on Medicare, she's on an insurance where she doesn't need referrals. So when I wouldn't respond with her order, she'd just go to her specialist of choice that she'd find and get what she thought she needed. And so I feel like our whole grounding in evidence-based research and scientific method, we're needing to find a new set of skills of bridging in communication to work with this percentage of the population that maybe don't share what our vision of being an ambulatory internist is. That's maybe too philosophical, but.
I think, Rita, I think your point in your question is the central one, right? On the one hand, we have these CAPS measures that we've hinted at, we think are outdated and don't measure everything. They're not comprehensive. They focus oddly on certain narrow aspects of interactions and miss everything else. And on the other end of the spectrum are these types of user experience. You can imagine these more modern-y type experience measures. It could be things that, like we've talked about, you know, imagine a QR code on the door that on the way out, you know, scan this QR code, provide your feedback. And it's a simple 3-star, 4-star rating or whatever. You can do it real time, almost like when you're walking out of a bathroom. Is this bathroom clean? Boop, green button. Do we want that? Because I think my worry is that with the user consumerism type movement, if we're not involved in having this kind of conversation about what do we want these measures to look like, we're going to go to that other extreme and inadvertently reinforce that type of consumerism movement. Again, some people I know are proponents of the consumerism movement, but for those who are a little more skeptical or critical of it, we could end up there if we don't think hard about this question. Couple questions, it looks like.
This is a very provocative conversation, and I appreciate it very much. I'm struck with an economic aspect of this. So, I mean, if you went back 100 years ago, when we really almost all medical exchanges were economic transaction directly between a physician and patient, a big part of the patient experience was how that was managed. So, you know, there's your bedside manner and the effectiveness of your diagnosis, but it's also what bill do you send, how aggressively do you collect it, how much, you know, and we've sort of abdicated that to a system now that pays for it. And it strikes me that this now falls into this place where it's a huge part of the care we provide, and yet it happens in kind of an economic black hole. There's actually, of all the enormous amount of money that patients now contribute in the form of premiums to pay for their health care, you have patients like yours, Annie, who say it's my right to message you, and you have Bob Wachter's reality, which is we turn this thing on and we haven't devoted any of those resources to this. And so, and yet we now have, you know, we've played a little bit with charging for it. And so, I mean, it strikes me that there's a bigger issue, which is we need to systemically address the fact that this is important work to do. And it almost feels like getting the cart a little ahead of the horse to evaluate the experience of something we're basically giving away for free, and not really thinking about it. This is part of the care we provide, that we have time allotted to it, and what is it that we, you know, because there's this huge spectrum of what we do with it. Do we provide a lot of care to it, or do we just use it as a way to try to get our patients in? And where do we draw those lines, and how much of that do we delegate? I mean, I'm sorry, I'm opening a whole Pandora's box here, but I am interested in your thoughts about that from an economic perspective.
And I think you also are asking a really important question, which is the cart and which is the horse? And one of the hypotheses of this talk is if we could find an innovative way to incorporate patient experience assessment in digital communication, would that help move the economic model? Because here we are 5-6 years into this in a big way or more, and we haven't. And, you know, the message appointment is an excellent example. Good for patients, not good for doctors, very low adoption to it. And yet it could be a really good low cost option for patients to get quick information if we decided to charge for it. But so far we haven't. Some systems have. It's been controversial. So, you know, I do think, you know, if we really could show the benefit for patients of that in an assessment, would that help move that economic decision forward? And I don't have an answer here on the cart and the horse, but I think it's an important question.
A comment in the chat from Mindy saying, I just got a message from a patient saying they'd spent a good amount of time clearing out their messages and realized they'd sent a lot to me over the last 5 years, writing to say they were sorry and to thank me for dealing with all these things. So patients do realize the message burden.
Yeah. I've had similar experiences with patients saying that to me. I had a patient just the other week who wanted to have a follow-up call about a test result and asked me in the message to have such a call and just to be sure I sent the bill. And I was like, oh, that would be quaint and an interesting approach, but not exactly how it works.
It doesn't.
That's the older model, though. That's an interesting expectation. That was.
So thanks. Two questions, which I'm going to give you an opportunity to answer the first one first, rather than lumping them together. The first is, are there data looking at the effect of providers defining and setting expectations for the role of messaging, Livy, other, in perception of that and the effects?
Data in that
Yeah.
regard?
In particularly our research we did during the pandemic, and I think this came through in our work on Levy as well, where patients don't believe they've received proper education on how to use either of these tools. And in some of our work, I've proposed kind of a grid that we could adopt as a clinician group where, you know, sort of you could anticipate by an initial message maybe which way it should be handled, and we'd have almost sort of practice guidelines that could be communicated with patients. But in general, that type of education, and I think on the positive of the fact it hasn't been done, it does allow us the autonomy because, as I'm sure all of us that are clinically active see, a lot of variability in how individual clinicians manage their messages and what they allow sort of in messaging.
Yeah, I would just add that one of the things I've heard people talk about using AI for is to do that real time. So a patient sends in a message through the portal, instead of waiting even for the smart reply or waiting for your reply, what if they're actually engaging with an LLM from the start so that when a question is asked that's maybe not appropriate for that type of message, it can be immediately fed back. So using AI to solve some of these problems would be imperfect, of course, but that also came in my head with your first question.
Thanks. Yeah. So it seems like structural interventions, like defining role clarity for different technologies and members of the care team, is an important approach for improving patient experience. And to the questions on the slide, so the one on the left really depends upon what you're trying to achieve. So to extend the smiley face or frowny face in the airport bathroom, that may be actually just about as effective as pushing the door close button on an elevator, where it doesn't actually do anything, but it makes you feel better. Thanks to after the ADA. So my question is, are you trying to make patients feel activated, engaged, as being heard by pushing a button or providing feedback? are you trying to use this for an advertising recruiting tool? Our hospitals are cleaner than others, our chatbots are friendlier than others. Or are you using it to define and change structural aspects within the system that you're working? Because you need to have different measures for those different purposes, and those purposes may overlap. So just thoughts on that.
I mean, it's a great question. We have a collaborative group for you to join. I think the concern probably many of us have is that the answer to your question will be driven by largely economic interests. And if those are the main drivers, you can see how the trickle-down effect, what the implications are going to be for those types of measures. That's probably the concern. I don't know that I obviously don't have an answer to your question, although I really appreciate the framing of the problem.
And again, I would like to see some more data on how patients are experiencing digital communication in to help us come to some of those answers. I'm imagining there would be a way that Levy would take a person to an opportunity for real-time patient experience assessment. The problem is with the QR codes, Stanford's rolled these out in their ER, and apparently they're more vulnerable to patient identity theft. And so they've gone to like embedded tablets for some of the innovation trying to capture more real time. But again, that requires in person. And so I still think, and I think our organization is well positioned to consider some more innovation in how we could capture this data, which is sort of what I'm hoping to move forward in over the next, some discussion about that in the system over the next few months. But it's a great question.
Yeah, I think it also, there is, you were hinting at this, that the value of the research on the patient experience with these different technologies now, I think, is understanding those assumptions that people come to the table with. That 30% finding for Livy, the chatbot, is not unique to healthcare. In other industries, the data are very similar, that 30% of people don't recognize a chatbot on the insurance site, as an autonomous computer. So not unique to healthcare, but I think really important to know. We've been really lucky with Matt Andazola at UC Health. Those findings are being used to help change how Livy introduces and how often Livy reminds people that Livy's a computer. It's simple stuff. This goes back to your prior question. It's simple stuff like Livy introduces itself as a virtual assistant. And you might say, well, is that the best way? Are there other words we should use to try to help with that transparency question? So again, I just think understanding how patients come to the table regarding these technologies is really important, and also, of course, changing probably unbelievably fast. I think repeating our study in 6 months probably has a totally different result.
We have one more question and then we'll wrap up for time. In the chat, as a patient, what's the incentive in scheduling a visit when you can possibly get free care through messaging, followed up by saying it seems like it's our responsibility to put up these boundaries on a system level?
Yeah. Yep.
I would challenge the question. Again, I think the redesign is what we need, because if it's an appropriate question to handle with a message, why do we require a visit? If we're really motivated to meet people at the right level and contain healthcare costs, there are some appropriate things to do over digital communication. And yet our revenue model doesn't support that. So I mean, I'm caught in the middle with everyone else since I get the same pressures we all do.
Yeah, I think that's why the question on the right of this slide is so important, is you can't, on the one hand, you can't separate that from the system level issues that affect it. On the other hand, could this be an opportunity to really rethink some of that, rethink the way care is designed? I go back to the LLM interchange, like You know, it might be nice to have a real-time back and forth interchange about a patient's question, then come to you rather than message, 2-day delay, response, oh, this pharmacy, oh, 2-day delay, oh, now about this, oh, I wanted 90, not 30, oh, okay. Like a chatbot could actually get all of that very quickly and then send it to you and be done. There's a lot of potential.
Dr. DeCamp, thank you so much for taking the time and sharing this information with us. We clearly had a really invigorating discussion on all this, and we all have our own experience as clinicians and as patients too, but most of our experience on average is probably as clinicians, so I think it's so helpful to see the data behind what patients experience, so thank you very much.
That was your laptop, huh? Did it work?